Okay, it's John Kanellopoulos in our laser center here in Athens, Greece, and you can tell by just looking at this anterior segment OCT that we're dealing with keratoconus. The teachings here is that on the map on the right, the fact that the epithelium is blue at the thinnest part of the cornea, which is shown on the map on the left, tells us that this keratoconus is active. The patient is rubbing their eyes, or they're wearing a artificial lens, which in this case, the patient is not. So we have active keratoconus. Thinnest cornea is at 462. We're going to see the Pentacan maps in a little bit. And this is the treatment plan with the EX500 excimer laser, the Contura software. As you can see, it will try and treat first a superior hyperopic arc, and we try and enlarge that with the largest possible transition zone. Unfortunately, that's not available in the US. We can only go to 6mm diameter. Here we're treating 5mm diameter with a maximal transition zone. I'll try and jump into the Pentacan of this case so we can correlate a little bit better there we go. So this is the Pentacan of the case. We correlate a little bit better the astigmatism, the thinnest part of the cornea, and anterior posterior elevation. And we can correlate here why is it that the software reads and treats the peak of the cone, and then it will treat an arc away from the cone to normalize the cornea by steepening the area superior to the cone that is flat. So the way we design this is obviously we want to remove minimal corneal thickness, and in order to do that, we will have to manipulate this correction. It's currently set at 0 refraction. The patient's refraction is -1, -125 at 35, but we know that since the steepest K on the Pentacan is over 50, it's 54.3. We know that since the steepest K here on the Pentacan is 54.3, we're probably dealing with more than 5-6 diopters of myopia. So by reshaping this cornea, we're probably going to end up having some residual myopia left over, which for the patient may seem as if myopia has been created. Because in the refraction, the patient picks probably a sweet spot somewhere along these lines, which does not represent the actual steepest part of the cornea or the cornea thickness. And you can see here how the patient has shifted the angle kappa in order to be able to view through here, and that's not the center of the cornea. So we will try and treat some of the cylinder, and the topographic cylinder is 291. We will treat here the maximum possible, so probably a 175. We will treat on the axis of the topography. It doesn't seem to be that far away from the refraction, which is unusually. The common case is that the refraction is completely different cylinder axis than the actual topographic, and we will treat arbitrarily maybe diopter myopia here. So this will be our treatment, -1, -175 at 33 degrees. Maximum treatment over the cone, 15 microns. We can handle it. We have over 450 microns minimal thickness. And this will be treated at an optical zone of 5mm with a transition zone of 2mm. If this was a US patient, we'd have to treat at a minimum 6mm optical zone. And we would add to this 2.5 diopters of myopia on the Contura treatment, and then treat a wavefront optimized plus 2.5 to account for the PTK, which here will be, since outside the US we can do a PTK, we'll use the same device to do a PTK, 8mm diameter, 40 microns thickness. So this is how we designed the Athens protocol. CXL will follow 6 milliwatts per centimeter square for 15 minutes. This is John Kanellopoulos signing out.